Hey, this week's topic is pulmonary edema, acute pulmonary edema in the pre-hospital setting, specifically cardiogenic pulmonary edema. There is a difference, and we'll talk about that. So we're going to focus on the pharmacological interventions for acute cardiogenic pulmonary edema in the pre-hospital setting. So first things first, the most important thing to understand about pulmonary edema is that it is not a primary respiratory issue. Obviously, there's a major respiratory component that we have to recognize and we have to be able to treat fairly quickly in some situations because airway and breathing are the most important thing. We have A, B, and then C, right? But you've got to remember that pulmonary edema is caused by a heart problem. So let's recap on congestive heart failure for just a moment because that is one of the most common reasons that you're going to need to treat acute pulmonary edema in the pre-hospital setting. So what is CHF? Well, congestive heart failure occurs when the ventricle, for whatever reason, is unable to pump enough blood to meet the demands of the body to start with. So these patients are often really shocky, right? They may have a low blood pressure, and oftentimes you'll see a really, really high blood pressure with the acute pulmonary edema patient. We'll talk about why in just a few minutes, but they are a shocky patient. They're either compensating or decompensating in shock. It's a cardiogenic issue because the ventricle is not able to either fill. So if it can't fill with blood adequately, it's called diastolic heart failure. And of course, if you can't get blood in the heart, then you can't get blood out of the heart. So therefore, cardiac output is decreased, and that's where the heart failure part comes from, or the shock part comes from, I guess I should say. And the other type of heart failure is systolic heart failure, which we're probably a little bit more familiar with. Systolic heart failure is commonly caused by an injury to the heart muscle, such as a heart attack, which causes the heart muscle to not be able to contract efficiently. And the term that we use to describe how efficiently the ventricles are pumping is called ejection fraction. And ejection fraction is very similar to stroke volume. The big difference is stroke volume is measured in milliliters, whereas ejection fraction is measured in percentage. So we may say that the patient has a 75 milliliter, and I'm making numbers up, right? Let's just make up some number though and say it's measured in milliliters for stroke volume, but they've got a 35% ejection fraction. Ejection fraction is normally 70%-ish or a little north of that, okay? That's normal in a normal functioning heart. When you get down into the 30s, 40s%, maybe less than that, then obviously you're not getting the blood out of the heart that you need to. If the blood doesn't leave the ventricle, then blood starts to back up in the ventricle because I don't necessarily have a preload problem, and unless it's diastolic heart failure, I don't have an issue with filling, right? So that means that blood starts to back up into the ventricle, and the ventricle is already full of blood, but the same amount of blood that would normally come to the ventricle is also returning to the ventricle, so that blood has to go somewhere. So it backtracks and it backflows from where it came from. So if it's left-sided heart failure, then you're oftentimes going to see that blood back up into the lungs. If it's right-sided heart failure, you're oftentimes going to see that blood back up into the periphery, and you'll have pulmonary edema, jugular venous distension, things along those lines. So when we're talking about treating acute pulmonary edema caused by cardiogenic shock, more than likely caused by congestive heart failure, we are talking about left-sided heart failure, and it doesn't matter if it's systolic or diastolic because your signs and symptoms are going to be the same. So what does the patient present like? Your patient could be mild, moderate, or very severe. It depends on the situation. Worst case scenario, your patient's pale, cool, diaphoretic, unresponsive, and they sound like bubbles. You hear bubbles when you walk into the room, right? This patient is probably perimortem, or we're going to have to do something very, very quickly, or there may not be much that we can do to remedy their situation, unfortunately. More commonly, when we get to the scene of congestive heart failure patients, pulmonary edema patients, they're in that late moderate stage. For some odd reason, pulmonary edema patients like to wait until the very last possible minute to call 911 right before they're fixing to die. I don't know why they do that. I guess they're tired of hospitals, and I don't blame them. But regardless, oftentimes our CHFers are pretty bad off when we get there to them. So we have to be able to respond pretty quickly and act fast. There are other interventions that we can consider providing for the pulmonary edema patient, but today we are focusing specifically on the pharmacological interventions, so we're going to bypass some of the respiratory components, okay? So again, the most important thing to remember about acute pulmonary edema is that it is a cardiogenic issue. So we're going to focus on treating the cardiogenic aspect. So to start with, the number one way that we reduce the amount of blood that's backing up from the heart is we reduce the amount of blood that's getting to the heart. And we do this by reducing preload. So if we limit the blood flow getting to the heart, into the heart, not to the heart muscle, but limit the blood flow that's getting into the ventricle, then we're not going to have as much backflow, if that makes any sense. Additionally, the drugs that we give that reduce that preload, so we're not overfilling the ventricles anymore, they also tend to reduce afterload. So that makes the heart makes it easier for the heart to pump, right? Because afterload is defined as the resistance in which the heart must pump. So let's say if I was to dilate arteries in the periphery, then it's going to be easier for the heart to pump through that big nice open artery than it would that really tiny narrow opening in the artery. So we decrease afterload and we decrease preload. These are technically preload reducers that we're talking about. That's what they're classified as, but just know that they do dilate peripheral arteries, which does reduce cardiac afterload and reduces cardiac oxygen demand. So the very first drug that we're looking for is nitroglycerin. Nitroglycerin is a drug that you're really familiar with already from your EMT class for the treatment of chest pain, and it works in the exact same way for the management of acute pulmonary edema. So we know that nitroglycerin is a vasodilator. There's a couple of different trade names for that, nitrostat being the most common. We know that it dilates arterioles and veins, so therefore it reduces preload and it reduces afterload. In higher doses, it does dilate coronary arteries, which is our goal when we're treating ischemic cardiac chest pain. And the dose that we give, 0.3 to 0.4 milligrams sublingual, is actually a very high dose. Just know that. We'll look at an IV drip here in just a moment. We'll see how big of a difference there is in what we're giving IV versus what we're giving sublingually or even transdermal. So the onset 1 to 3 minutes, duration 30 to 60 minutes. Now that's kind of subjective and it depends on the route in which it's administered. Excuse me. Indications: ischemic chest pain, and what we're talking about today is congestive heart failure with pulmonary edema. So our goal here is to open up the vessels that lead to the heart, right? So we're looking at veins. We're causing venous dilation, which is going to reduce the blood flow going to the heart, which is going to make it easier for the heart to pump. I know that sounds counterproductive. There's a whole big long story behind this, and we will talk about it in depth next semester. But we're not going to do that today. All right. So side effects, exactly the same as what you're familiar with from your EMT school. We want to make sure that your patient has an adequate blood pressure, typically greater than 100. Follow your local protocol. Some protocols say 110 millimeters of mercury systolic. Our dose for cardiac chest pain, or in this case in pulmonary edema, is 0.3 to 0.4 milligrams sublingual. That could be either a tablet or spray. Typically your tablets come in 0.4 milligrams and your spray comes in 0.3 milligrams, but that could be subjective as well. And we can give this every 3 to 5 minutes. The difference here versus your EMT protocol is there is no maximum dose for your nitroglycerin anymore. We give this quote-unquote as needed. So how do you know if it's needed? Well, if it's chest pain and it reduces their pain, once their pain goes away, do I still give it? Of course I do. And the reason for that is because we don't give nitroglycerin to treat pain. We give nitroglycerin to dilate coronary arteries in the chest pain aspect so that we can continue to have good blood flow to the myocardium. On the other side of the boat here with congestive heart failure, once we start to open up the periphery and we limit the blood flow back to the heart's able to start working a little bit easier, and the blood pressure starts to come back to a normal level, the patient's level of distress starts to lessen, and they're breathing a little easier. All their vital signs are starting to trend in a positive manner, so we stop giving the med, right? No, we don't. We're going to continue this. Okay, don't stop. Always continue this. There is no max dose. Continue it as long as your blood pressure will tolerate, because this is helping the patient, I promise. Now, one thing that we cannot do as EMTs that we can do as medics, two things actually. We have two other routes of administration for nitroglycerin besides sublingual. We now have topical, which is called transdermal, and that transdermal is subjective as far as the dose goes. Follow your local protocol, because oftentimes the dose for transdermal is based on the patient's systolic blood pressure, but in general it's 1 to 2 inches. 1 to 2 inches, and it comes in a little tube, and you put this on a piece of paper, and that piece of paper has inch markers on it, and you just squirt it on the piece of paper to the appropriate inch marker. I'll put a picture of this on your blackboard, don't worry, and then you tape that to the patient's chest with the nitroglycerin side down. It's a transdermal administration. This is a slow absorption rate, so by the time that your nitroglycerin sublingual starts to wear off, hopefully this is starting to take effect, and this helps us from having to give sublingual nitro over and over and over and over and over. Additionally, The sublingual nitroglycerin, especially after multiple administrations, it starts to not be quite as effective. It's a process known as downregulation. We'll talk about that more next semester as well. The other neat thing that you can do as a paramedic is we can actually give nitroglycerin intravenous. So this comes in a glass bottle. We do have it on the truck in Onslow County. Onslow County is the only ALS agency that I'm aware of, in this area at least, I won't say in the whole state, but in this area, that is hanging nitroglycerin drips in the field. So nitroglycerin again comes in a glass bottle. Your starting dose is typically 5 micrograms per minute. 5 micrograms per minute. Check your local protocol for specific dosing because it may vary some. The state does not have a standardized dose for nitroglycerin drips, but typically you're starting at 5 micrograms per minute. A key note when you're using nitroglycerin drip, because it is in a glass bottle, it creates a suction. So the drip will run for a couple of minutes and then it will stop. You have to use a special tubing, and normally your IV tubing that goes in your IV pump already is this special tubing. It's called vented, V-E-N-T-E-D. It's got a little tab on the side that you can pop open, and then there's a filter on the inside there, and it lets air get into the drip chamber so that it doesn't create that vacuum and it will continue to drip. If you don't open that vent when you're using a glass bottle, then your IV will not run, but just for a couple of minutes. Also, please try to use an IV pump if you have it available when you're administering nitroglycerin, because you do want to be very careful with your dose. All right, pregnancy category is C, so we don't want to give this unless we absolutely have to a pregnant person. Consideration, ED meds, erectile dysfunction meds in 24 to 48 hours. Ask. Don't be afraid. Ask. It literally could be a life-changing decision if they have taken their little blue pill an hour before you get there, and I give them 2 or 3 good doses of nitroglycerin, their blood pressure is probably going to be in the toilet. So make sure that you talk to people. Protect from light. We know that nitroglycerin comes in a dark brown bottle like a beer. That's because it is very light sensitive, so keep that in mind. And do know that nitroglycerin is going to give the patient a headache. If it doesn't give the patient a headache, it's probably not a good bottle of nitroglycerin. Not everybody falls in that category, I guess, but the overwhelming majority of patients that get nitroglycerin will end up with a terrible headache. Again, make sure that we use vented tubing. We're going to pause here before we go down to vasotech, and we'll do another video for vasotech.